Good morning. In this video, we are going to discuss the causes of chronic diarrhea through discussion of a clinical case. And we will discuss this over two videos because the discussion is rather long and the possibilities are multiple. We're going to summarize at the beginning the history of the patient. The patient is a 63-year-old female who was diagnosed 30 years ago of having systemic lupus erythematosus. And then later on, a few years after, when the disease progressed, she was diagnosed by the same medical doctor as mixed connective tissue disease. And this was 30 years ago. She was still 32 or 33 years old. Over this long period of time, she has been receiving 5 milligrams of prednisone once a day in the morning. And recently, like 2 or 3 years ago, she increased the dose to 10 milligrams per day. She increased on her own. She's a medical doctor, by the way. And the cause of this increase was the increasing muscle pain of the autoimmune disease and joint pain, which was not mainly originating from her autoimmune disease, but originating from osteoarthritis. She had a fourth degree osteoarthritis in both knee joints. She used to take 25 milligrams of cataflam per day for years and years. And then similarly, recently, like 3 years ago, she increased the dose to 50 milligrams because she couldn't tolerate the pain. And in addition to this, she used to take 2 tablets of Panadol, usually Panadol Advance, every 12 hours, and the proton pump inhibitor, Nexium, 20 milligrams twice a day. She presented with recent loose stools. So she has recently suffered from loose stools and frequency of defecation. So it's a kind of diarrhea. And that diarrhea was lasting for a month, the time she presented to the clinic. And it wasn't responding to any of the medications that are usually used in these conditions of diarrhea. So she tried Antinal, which is an antibacterial medication, and she also tried metronidazole, which is Flagyl, and this is the scientific name, but there was no response. What was very characteristic is that defecation was preceded by severe bloating and distension. But that bloating wasn't around the umbilicus, for example, or in the central part of the abdominal cavity, but it was in the region of the stomach. Because she is a medical doctor, she described it as being epigastric pain. And she also said that this severe pain was relieved by defecation. But after defecation and after the severe pain was relieved, there was residual tenderness over the area of the stomach, over the epigastrium. This epigastric pain associated with bloating that that followed every meal and that preceded every defecation was at the beginning of the condition very severe. And it started immediately after meals, but later on the condition improved a little bit and the epigastric pain was a bit improved. But there was also, even when there wasn't that severe pain, there was severe discomfort and fullness after meals, especially after breakfast. And it was associated with lethargy and lightheadedness. She couldn't do any activity immediately after breakfast. Diarrhea was sometimes more than just loose stools and frequency. It was a watery diarrhea to the extent that sometimes she suffered from incontinence. Of course, taking into consideration that she is an old lady. She is 63 years old. She has an autoimmune disease. She has been suffering from an autoimmune disease for 30 years, and this gives you the possibility of a possible neuropathy. And in addition, something that's not written in the sheet here in order to make it shorter, that she, like 8 years ago, she had a surgery on her cervical vertebrae because her spinal cord in the cervical region was kinked, and they had to break the lamina, the posterior lamina. So we are expecting neurological symptoms to occur as complications of that surgery. But let's focus again on the digestive symptoms. This diarrhea wasn't associated with nausea or vomiting. There was very minimal weight loss at the beginning. So we can't say that there was significant weight loss. There wasn't any fever. And except for 1 or 2 days when she felt a bit like shivery, but this lasted for a very short period of time. What's most remarkable is that the stool analysis was negative, meaning that there wasn't any bacteria, no pus cells. Of course, maybe because she has taken anti-anal and anti-bacterial medications for like a week. And it was also negative for the H. pylori antigen in the stools. And there wasn't any blood in the stools. Of course, being a medical doctor, she referred to our clinic, and she sought help because she understood that it was necessary to undergo further medical investigations rather than just trying additional empiric treatments. A month of persistent diarrhea in an old lady that is 63-year-old that has an autoimmune disease and that is on chronic steroid therapy for 30 years, of course, has a broad differential diagnosis and several possibilities that should be taken into consideration. Let's make like a summary or wrap up the important data that we had in the history. First of all, she is 63 years old, so she is an old female, old lady. And she has a long-standing connective tissue disease, and it is a mixed connective tissue disease, meaning that she has an element of systemic lupus, an element of scleroderma, and it was actually, she has been tested for scleroderma, and she was positive at the beginning, and then later on, the results were negative. She has been on prednisone for 30 years, and she has recently increased the dose, and this, of course, raises the possibility of immunosuppression. Daily cataflam or diclofenac, of course, can cause gastrointestinal damage, not only damage to the stomach, and we will see why in our analysis, but also damage to the small intestines. Among the data, we also have something very important, which is that the diarrhea lasted for a whole month, and it was profuse, and it sometimes caused incontinence. The severe epigastric bloating is an important sign because it might indicate fermentation, for example, because bloating usually results from an overgrowth of bacteria, because bacteria usually produce gases. But when there is excessive or overgrowth of bacteria, then there will be excessive fermentation, and the excessive fermentation might be the cause of this epigastric bloating. And of course, the gases do not only cause bloating, but also gastric distension, and therefore this might explain the severe pain that was before bowel movements and that was somewhat relieved by defecation. And also explains, of course, the fullness and discomfort after meals. The stool analysis was negative for bacteria, and it was negative for common parasites that might cause this clinical picture, like H. pylori, that lives in the stomach, and another rare one, a unicellular organism, like you see here, that lives intracellularly, meaning that it lives inside the intestinal, the luminar intestinal cells. The intestinal cells that surround the lumen, the epithelium of the small intestine. This is how cryptosporidium looks like. But it was negative for cryptosporidium, and you know that in order to exclude cryptosporidium, the patient has to do 3 consecutive stool analysis on 3 different occasions. What's also important in the data is that there wasn't any response to metronidazole or anti-diarrheal and no blood in stools. What is the differential diagnosis? The first one, and the very high on the list, we have enteropathy or colitis, inflammation, that is called by diclofenac or cataflam or any non-steroidal anti-inflammatory drug. So daily diclofenac or cataflam can damage not only the stomach, but the small intestines and the colon. Why? Because diclofenac inhibits certain important enzymes called cyclooxygenase 1 and cyclooxygenase 2. And because it inhibits both enzymes, we say that it non-selectively inhibits those enzymes. And those enzymes are important because they produce prostaglandins, and prostaglandins are important because they maintain health of the gut by maintaining blood flow to the gut, by producing mucus that is protective, of course, it makes like a mechanical barrier against HCl and pepsin. And prostaglandins are also important for secreting bicarbonate to neutralize part of the acid. If we don't produce enough cyclooxygenase 1 and 2, then there will be inadequate protection of the stomach. There will be increased acidity and harm to the wall of the stomach. So the digestive tract lining in general will be vulnerable to the stomach acid, to the digestive enzymes like digestive enzymes like pepsin, and even to the bacteria. Can bacteria injure the gastric mucosa? Yes, of course, because as we will see later on, bacteria can produce toxins, and these toxins can damage the stomach wall directly or indirectly. Directly by causing inflammation, indirectly by killing the mucus secreting cells. So if you don't have enough prostaglandins because of diclofenac, then you will have ulceration of the wall or inflammation of the wall. And of course, the inflammation will cause abdominal pain, and the inflammation will irritate the intestines and the stomach and increase peristalsis and therefore increase diarrhea. But there will also be protein loss, and we will explain why very soon. There is also microscopic bleeding. When we say microscopic bleeding, we mean that the patient might not come complaining of bleeding. It's not visible in the stools, but it needs microscopic examination. Why would there be protein loss in case of non-steroidal anti-inflammatory drug-induced colitis? This is because diclofenac damages the wall of the small intestine. And it's a direct damage, and it causes a leaky barrier. What is a leaky barrier? This means that the intestinal epithelial cells that are usually very tightly connected will have these tight connections disrupted, and this will allow the intestinal epithelium to be more permeable to the bacteria that will pass from the inside of the small intestine to the inside of the mucosal cells or to the tissues in between. So these proteins will seep out of the digestive tract, and this will cause what we call protein-losing enteropathy. Why would there be diarrhea in case of diclofenac? Number one, we have malabsorption of fluids and nutrients. So if you take diclofenac, you wouldn't be able to absorb all the fluids from your diet, for example, all the water, to return it to the blood, and even the soluble nutrients that result from digestion. Why? Because in case of damage to the intestinal epithelium, these villi, these projections that are normally present in the intestinal epithelium to increase the surface area for absorption, these villi or villus projections will be flattened. Here, they are flattened because of an autoimmune disease that is called celiac disease, but the same occurs in case of diclofenac. It causes first inflammation and then flattening upon healing by diclofenac. And therefore, if you have flattened villi like this, then you lose this advantage of having a large surface area, and therefore there will be diminution of the absorption of all the useful contents in the small intestines, like water, like monosaccharides, like amino acids, like glycerol, and bile acids. When the water is unabsorbed and when the bile salts or acids stay in the lumen of the small intestine, they adsorb this water and make the stools very watery. I'll stop sharing for a while to make sure that I'm sharing the correct document, and then I'll reshare. Okay. So diclofenac diminishes the absorption of water and causes diarrhea. The second cause why we have diarrhea in case of diclofenac is what we have just been explaining, which is the leaky barrier or the exudative leakage. We said before that when there is inflammation, there will be these are the tight junctions that I've just been explaining or talking about, and they cause the intestinal epithelium to be tightly connected. And we can see that in case of inflammation because of diclofenac, that these tight junctions or barriers are damaged, and they allow, therefore, the leakage of bacteria and the leakage of proteins. So just like we explained with protein loss, the intestinal wall will become highly permeable and it will weep. It's just like weeping. It will weep fluid, it will weep mucus, and it will weep plasma into the digestive tract. This means what? This means that the leakage is both ways. Meaning what? Meaning that when the tight junctions are damaged like this, we will see that some toxins and some bacteria, some pathogens, will pass from the gut, the lumen of the gut, the cavity of the small intestine, through this leaky barrier to the blood. And when the pathogens pass to the blood, although they shouldn't, then they will cause bacteremia, toxemia, and all these harmful phenomena that might result in diseases. But similarly, the plasma might pass the wrong way. Plasma might pass from the blood to the inside to the cavity of the small intestine together with any extra fluid, and this represents a volume overload to the bowel and therefore results in voluminous watery stools. A third mechanism by which diclofenac causes diarrhea is an altered intestinal motility. You know, of course, that there is constant peristalsis in the wall of the gut, because the wall of the gut is made of, or the mucosa of the gut actually is made of, contains smooth muscle fibers, and these smooth muscle fibers contract and relax in a regular way, called peristalsis, and peristalsis helps pushing the bolus of food downward, as we have explained in the videos for grade 10 biology. But when there is inflammation in the wall of the gut, then this local inflammation will trigger the local nerves, and the local nerves will be irritated. And when they are irritated, they are overstimulated, and they alter intestinal motility meaning that the alteration will be an increase in motility and not a decrease in motility. So peristalsis will be very fast, not only very fast, but erratic, meaning that it is irregular, and it pushes the contents through the gut downward very rapidly. And when the contents of the gut are pushed downward very quickly in the small intestine and in the large intestine, there wouldn't be enough time for absorption of water. And this is even the mechanism by which bacterial toxins cause diarrhea. They increase intestinal peristalsis, and the increase in intestinal peristalsis does not give enough time for water absorption. The last mechanism for diarrhea in case of diclofenac is bacterial overgrowth, because when you break down the protective barrier and cause inflammation, this will change the gut chemistry, and it allows a shift in the bacteria, meaning that there will be an overgrowth of the harmful bacteria, and there will be what we call dysbiosis. Dysbiosis is a change in the ratio of friendly flora to pathogens in favor of the pathogens. So you will have an overgrowth of pathogens because of the inflammation and the toxins that result from inflammation. And this favors the bacterial, the pathogens, and this results in, as I mentioned at the beginning, fermentation, excessive fermentation, and therefore excessive abnormal production of gases. But this diarrhea might also be a manifestation of the autoimmune disease itself, of the mixed connective tissue disease itself, because as I also mentioned at the beginning of the video, the autoimmune disease results in affection of the nerves, because the autoimmune disease causes vasculitis, or inflammation of the blood vessels, of the small blood vessels, including the small blood vessels that supply the nerves. So the nerves, when the small capillaries and the small blood vessels are affected, then the small nerves will also be affected. Then when you have autoimmune vasculitis, you will definitely have autoimmune neuropathy, not only because of vasculitis, but because of other metabolic disturbances as well. But this neuropathy means what? Means that the sensory and motor nerves will not be functioning properly. And since the motility of the gastrointestinal tract is dependent on innervation, then there will be dysmotility. And dysmotility means that the rate of peristalsis will not be normal. And usually here, in contradistinction to what we have just been talking about of increasing peristalsis because of bacterial toxins, here the esophageal dysmotility will be a sluggish motility. Motility will be slower, peristalsis will be slower. There will be gastroparesis, meaning that the stomach will be lazy, and that the peristalsis and churning in the stomach will also be slow. The same applies to the small bowel. And when there is low motility in the gut, there will be stagnation of the contents inside the gut, and this will result in bacterial overgrowth. So this is what we call SIBO, SIBO, or SIBO, which is the small, which stands for small intestinal bacterial overgrowth. It also might result in a more serious condition called intestinal pseudo-obstruction. Pseudo means false, meaning that this is not a true mechanical obstruction, but it's a functional obstruction because of the very sluggish peristalsis. And this explains the bloating, because sluggish peristalsis results in dysbiosis, overgrowth of pathogens, and bloating. As I've just explained, there are specific mechanisms for the sluggish peristalsis and the dysmotility in the mixed connective tissue diseases. The first one is microvascular damage, especially when the mixed connective tissue disease has an element of scleroderma, because scleroderma is characterized by having vasculitis and inflammation of the very small blood vessels. Then there would be narrowing of these blood vessels and poor blood flow to the mucosa of the digestive tract, including the nerves. So part of the sluggish peristalsis is due to the poor blood flow to the muscles themselves, but part is an indirect one, which results from a poor or sluggish blood flow to the small nerves, sensory and motor, that supply the musculosa of the wall of the gut. The second factor is collagen buildup. Collagen is a protein fiber that gives elasticity, but excessive accumulation of collagen, of course, diminishes the elasticity of and the motility of the gut. So collagen buildup is a kind of fibrosis because it's an extensive fibrous overgrowth. Collagen buildup occurs here because of the autoimmune disease. There is an overproduction of collagen in many autoimmune diseases, in particular in scleroderma. Where are these collagen fibers going to deposit? They will deposit in between the muscle layers of the esophagus, of the small intestine, which makes them, as I've just mentioned, stiff and unable to contract properly. But as I've just said, nerve degeneration is one factor, because we have nerves that supply the gut, and they are, of course, autonomic nerves, meaning that they are involuntary nerves, sympathetic and parasympathetic, and they give motor orders to the muscles to do peristalsis and squeeze the food downward. Then if these nerves are degenerated because of the autoimmune disease, then there will be a very slow peristalsis or even absence of peristalsis, aperistalsis, and this results in stagnation of food in the gut, and as we have said, heartburn, etc. But we have two new symptoms here that are interesting to understand. GERD, which is gastroesophageal reflux disease or acid reflux. Sometimes you feel that you have heartburn, that some acid returns from the stomach to the esophagus, and this is because of the weak sphincter or weakness of the sphincter that lies between the esophagus and the stomach, because of nerve degeneration. Another very serious symptom that occurs is dysphagia or difficulty swallowing. Of course, if the muscles have slow peristalsis and if the nerves are not functioning properly, then there would be difficulty to give orders to the muscles of the pharynx and the esophagus to contract, and there will be difficult swallowing. The third cause that might be associated with chronic diarrhea is microscopic colitis. Usually the suffix itis indicates inflammation. And usually when we have inflammation, we think about infection or about inflammation, for example, autoimmune inflammation. Microscopic colitis is not caused by infection, but it is caused by inflammation of the lining of the colon. And this inflammation characteristically cannot be seen even if you use even if you use an endoscope. This inflammation in the lining of the colon is not gross inflammation that can be seen easily, but it can be seen easily when you take a sample of the tissue and examine it under the microscope. So it's not, for example, an ulcer that you can see easily when you introduce the colonoscope, but you need to take a biopsy through the colonoscope and examine it under the microscope. That's why we call it microscopic colitis. And the typical patient is an old female that uses non-steroidal anti-inflammatory drugs or proton pump inhibitors, and we will know why, and having an autoimmune disease. So starting from this information, we can say that the microscopic colitis is essentially an autoimmune colitis, but why isn't it, for example, categorized under inflammatory bowel disease? This is because it is microscopic. You cannot see gross changes in the mucosa of the large intestine, but you have to take a biopsy and examine under the microscope. The typical symptoms are chronic diarrhea, watery diarrhea, normal stool examination, no bacteria, no fungi, no blood, and a normal colonoscopy, and only diagnosed by biopsy. The exact mechanism of colitis is not known, but one of the causes, in addition to autoimmune diseases, is the PPIs, or the proton pump inhibitors. Why? Because of many factors. Number one, they alter bacterial flora, of course, because the proton pump inhibitors alter the pH. They inhibit proton pumping, they diminish acidity in the stomach, and therefore they alter the microbiome. They cause a disbalance or an imbalance in the normal microbiome inside the stomach and the gut. So they disrupt the gut environment in favor of the pathogens. Furthermore, they trigger immune responses, and we will see how. There are several theories that explain the occurrence of chronic diarrhea in case of proton pump inhibitors. The first one is the leaky barrier syndrome, or the increased gut permeability. As you can see in the diagram, these are normal intestinal epithelial cells. Where the tight junctions are not shown here, but there are tight junctions in between them, and then because of the proton pump inhibitor, we are now having a leaky gut, and the intestinal permeability is increased, and you can see how the bacteria and viruses can enter in the bloodstream. So they allow antigens and bacteria to penetrate the mucosal lining and even reach the blood. And when they penetrate the mucosal lining, which is not a normal ordinary event, they will trigger an inflammatory response because, of course, they are considered foreign antigens, and they will stimulate the immune response and trigger inflammation. So we understand now that the increased permeability, or the leaky gut, will result in inflammation. But why do they increase intestinal permeability? Number one, they increase intestinal permeability by the dysbiosis they cause. We have just mentioned this, by altering the gut microbiome. But what is the relationship between altering the gut microbiome, or dysbiosis, and increased permeability? First of all, as we said, why do they alter the gut microbiome? Because they increase the intestinal pH. And the increase in intestinal pH encourages overgrowth of pathogens. And this dysbiosis will cause direct toxic damage to the intestinal cells, meaning that these bacteria that have overgrown will release toxins and will cause toxic damage to the intestinal cells. They will damage the mucus secreting cells and diminish protection of mucus. They will cause inflammation, of course, and this is how, or this is one mechanism by which the proton pump inhibitors cause increased permeability. Why do they increase or how do they increase permeability? By causing dysbiosis, and the toxins of the bacteria will cause inflammation of the epithelium, and when the epithelium is inflamed, the tight junctions are lost and the epithelium becomes leaky. The second mechanism is a mechanism in which the epithelium becomes leaky and those tight junctions become damaged, but even without this intermediate step of dysbiosis or bacterial overgrowth, and we call it direct disruption of the cellular tight junctions. And you can see, of course, here the tight junctions, and you can see two important proteins that link the intestinal epithelial cells tightly together, which are clodin and occludin. So they disrupt clodin and occludin tight junctions. Tight junctions are very important in intestinal epithelium because the intestinal epithelium is all the time exposed to shearing forces and stressful tension forces. Then there should be tight junctions to prevent leakage. But we also have collagen production. Some proton pump inhibitors, in particular lansoprazole, stimulate certain cells in the colon to produce collagen. They are usually producing collagen, but proton pump inhibitors stimulate them or overstimulate them to overproduce collagen. And this results in thickening of the wall, and this thickening of the wall is associated with the inflammation. So that's why it causes diarrhea, because we should expect thickening of the wall to diminish peristalsis. It depends. It depends on which is more powerful. Is colitis more powerful, or is increased collagen more powerful? If increased collagen is more powerful, is taking over, then there would be the lazy gut, and the lazy gut also causes diarrhea indirectly by causing stagnation and bacterial overgrowth and over fermentation. But if it is the autoimmune colitis or even the toxic colitis that is overriding, then there will be diarrhea because of increased peristalsis. One of the causes of chronic diarrhea is Clostridium difficile that is sporulated. And of course, you know that when the bacteria are sporulated, they have thick walls and they are very difficult to be accessed by antibiotics. We usually have Clostridium difficile in hospitals, but even without recent hospitalization, antibiotics, chronic antibiotic use or inadequate antibiotic use, including Flagyl, that is a medication against protozoa and not against bacteria, and chronic proton pump inhibitor therapy might increase the risk of Clostridium difficile. And in order to diagnose Clostridium difficile, you have a stool analysis done. And what are you looking for in the stools? You're looking for the toxin of Clostridium difficile. Of course, since the toxin is a protein, then you would detect it through a polymerase chain reaction or a PCR, and you can refer to the videos on DNA to understand this. Of course, tests that are done via PCR are expensive tests. One of the causes of chronic diarrhea is pancreatic exocrine insufficiency. You know that the pancreas has an endocrine part that secretes insulin and glucagon, which is the islets of Langerhans, and you have acinine that constitute the exocrine part of the pancreas. The exocrine part secretes very important enzymes that will be transferred via the pancreatic duct to the duodenum, the first part of the small intestine, like pancreatic lipase that helps digestion of fats, for example, like pancreatic trypsinogen that helps digestion of proteins. And like pancreatic lipase, pancreatic amylase that helps digestion of glycogen and starch. So if there is an insufficiency in the production of those enzymes by the pancreas, then there will be undigested food products in the small intestine. They would be fermented and they would result in diarrhea and bloating. And because these undigested food items cannot be absorbed, then they are lost in the stools, and this results in weight loss and fatigue. One characteristic of the pancreatic exocrine insufficiency is that the stools are greasy and they are floating on the surface of the water, and they are not easily flushed, and they are bulky, of course, because they contain a lot of water and undigested fat. Why are they greasy? Because they contain undigested fat. Undigested fat will not be absorbed and will be lost with the stools. And why do they float on the surface of the water? Because the fats have lower density than water. And then we have the celiac disease. Celiac disease is one of the autoimmune diseases that, or it is one of the accompaniments of autoimmune diseases. In celiac disease, there will be an autoimmune destruction of the villi. Here, you can see the villi, those processes this is a section, a longitudinal section in the villi, but here inside you can see the complete villi. But as you can see in the celiac disease, there will be flattening of the villi associated with ulceration due to an attack by the autoimmune system. And because this attack is a local attack, then it is the local immune system that is acting, and there are local antibodies called immunoglobulin A that are surface antibodies present on the mucosa. And therefore, if you have celiac disease, we are expecting immunoglobulin A, which is the local immunoglobulin, surface immunoglobulin in your tissues. So we do a test called tissue transglutaminase immunoglobulin A, and it is a blood test that is highly specific to celiac disease, and it detects the presence of antibodies in the blood of the tissue transglutaminase immunoglobulin A. These antibodies have been produced against your villi because the immune system has been confused and has attacked your body's own tissues. And this is the case in all autoimmune diseases. But one important thing is to avoid false negative results, because sometimes you have a low total immunoglobulin A, meaning that your total surface antibodies in the body have a very low level. And therefore, even if you have a local reaction in your gut because of celiac disease, your immunoglobulin A, your transglutaminase tissue immunoglobulin A, will not be elevated. And this is what we call a false negative test. So we do total immunoglobulin A together with immunoglobulin A in the tissue transglutaminase in order to avoid false negative results, or to rule out immunoglobulin A deficiency and therefore avoid false negative results. Of course, I forgot to tell you one important detail, that gluten is one of the major causes why celiac diseases occur, and why your immune system attacks your villi. But this requires a separate video to explain it. So people who have celiac disease are usually considered gluten sensitive and should have food that is devoid of gluten. The seventh cause of chronic diarrhea is bile acid diarrhea. It has the same symptoms that our patient was suffering from: chronic diarrhea, bloating, and frequent bowel movements. One of the major causes is excessive bile acid secretion by the liver, and this is abnormal. The other cause is colonic water secretion. Usually the colon should absorb water, not secrete water. But what happens in some cases that the bile acids, even if their amount secreted by the liver is normal, but some of them are not reabsorbed. And when they are not reabsorbed, they stay in the colon and they attract water, and this causes excessive colonic water secretion. So this is why we call it bile acid diarrhea, because it is either due to excessive bile acid secretion by the liver or due to diminished reabsorption by the gut, and therefore they stay in the gut and result in osmotic attraction of water. In both cases, it is due to bile acids, and the bile acids irritate the wall of the gut, increase downward peristalsis, and therefore increase diarrhea. And the tests that are done are a blood test, essentially, and the blood test is a test that indicates the level of bile acids in the blood to see whether they are adequately absorbed or not. The treatment is essentially by giving bile acid binders, molecules that are capable of binding the bile acids in order to prevent them from absorbing water and prevent them from irritating the gut. Of course, low-fat diet, because the bile acids function is not normal, or the liver function is not normal, and trying to balance the gut microbiome by, usually in any cause of diarrhea, you try to increase the friendly flora at the expense of the pathogens. We can increase the friendly flora, as you know from your study of grade 10 biology, by taking probiotics, fermented foods that contain friendly flora, like yogurt, for example, which is a very good source of lactobacilli, and that enriches your friendly flora in your gut microbiome. But you can also take prebiotic like fibers, because prebiotics are food for friendly bacteria. So when you take a lot of fibers, you are giving the friendly flora their food. We also have the colonic or colorectal cancer. One of the possibilities of chronic diarrhea is the presence of cancer, of course, in the descending colon or in the rectum, but the absence of blood here makes this possibility very low, but it should be excluded again by colonoscopy. Another cause is cytomegalovirus colitis. Cytomegalovirus is a very opportunistic virus, meaning that it is a virus that affects people only when their immunity is very low. And here it's a possibility because the patient is old and because she has been on prednisone for years and years. So the chronic steroid, of course, cytomegalovirus is very unlikely when immunosuppression is only due to cortisone, because the immunosuppression here is not that serious, but it should be taken into consideration, especially if there is no improvement. The last category of diseases are the inflammatory bowel disease. We've just mentioned celiac disease. It is one of the inflammatory bowel disease. It should have been included here, but the inflammatory bowel diseases in general are a group of chronic disorders that are characterized by persistent autoimmune inflammation of the digestive tract. The two important types that we're going to study are Crohn's disease and ulcerative colitis, and they are characterized by abdominal cramping, diarrhea, fatigue, weight loss, of course, but the most prominent symptom that makes a difference here is the low-grade fever. We will be discussing them on the second part of the video. I hope you found this video interesting and useful, and if you found it useful and liked it, then please click like, write your comments, because your feedback is very important. Try to share it with your colleagues, and Subscribe to the channel if you haven't already. Thank you, and see you very soon on the second part of that video.